As a kind of starting point, let's go ahead and welcome Sunita Soni. Sunita has been a consultant in sexual health and HIV in Brighton since 2010. She's a core member of the British Association for Sexual Health and HIV, the Bacterial Special Interest Group. She is lead author of the BASH Mycoplasma Genitalium Guideline and is on the writing group for the BASH Neisseria Gonorrhea Guideline. Sunita leads the undergraduate teaching for GUM, HIV, and medical students electives program at the Brighton and Sussex Medical School. So Sunita, please take it away.
Right, good morning everyone. Thank you very much for the invitation to come and talk to you at this conference. This is something new for me and Daniel. We've not, well, for me it is anyway, I've not spoken at a non-scientific, non-clinical meeting before, so I'm really interested to see what discussions we can have after this talk. And Ulla had kindly asked me to talk about AMR in a sort of clinical context. So I'm going to do my best with that, and hopefully it will stir up some discussion for later on. So my name is Sunita Soni. I'm a consultant in sexual health and HIV, and I work at the Sexual Health Centre in Brighton and Hove. So just to give you a bit of background and a bit of context, let me just, shall I just move this out of the way? So we are a large clinic, so proportionately for Brighton, which is a relatively small city, we have lots of STIs. We have the main clinic, Brighton and Hove Sexual Health, which is based in at the hospital site in Kemp Town, and we also have a walk-in clinic in the centre of town in Morley Street, and then another service, a much smaller service in the west of the city, in a GP surgery. So there's 3 sites that we're based on. Obviously we do quite a bit of outreach as well, and we offer services for sexual health for all the population of Brighton and Hove and beyond, Sussex wide. And really, you know, if you want to go to any sexual health clinic, you can. You don't have to go to the clinic in your area. We offer HIV services, so as part of my job I also do outpatient clinics for people living with HIV. We offer contraception, have specialist gay men's services where we offer them PrEP and vaccinations. We also have Clinic T, which is our clinic for trans and non-binary people, and that's every couple of weeks. And we also see people who have been sexually assaulted or are experiencing domestic violence, and we have signposting available for those people. So that's just some of the things that we do in our clinics. But today, the questions that I was going to try to answer in my talk are: what are the current challenges faced by STI clinics? Tell you a bit about STI superbugs and just introduce that concept. We're going to look a little bit at how antibiotic resistance can impact on our clinical work, and at the end I'll just sort of touch on what might be happening with respect to AMR in the future, or the ways that we can tackle that. Okay, so I'm showing you this because it's my favourite graph of all time. All STI clinicians love this graph because it tells you so much about the history of STIs with a socio-political context. So all the events that have happened in the last in the last 100 years and how they've shaped the incidence of STIs over time. So this graph in particular is gonorrhea. And if you go back to 1925, that's when we first started collecting data, because that's when venereal diseases clinics were set up. So we started to get the data and we could plot it on the graph. And you can see that just after World War I, there were lots of STIs, and penicillin was invented. So there's Fleming. We had penicillin, so you can see that STI diagnoses started to go down until the Second World War, when they shot up, and then everybody came home, got some treatment, and they plummeted again. And then over the next sort of 60s and 70s, there was a One Love movement. You know, there was lots of love and lots of sex and lots of drugs, and incident gonorrhea went up, and it hovered at quite a high level for a long period of time. And then obviously in the 80s, in the early 80s, the advent of AIDS, and it wasn't HIV, it was AIDS. Most people who were living with HIV were quite sick, and a lot of people died. And as a result of that, people stopped having sex. So the number of reported gonorrhea diagnoses plummeted in the early 80s, only to gradually come back up as antiretroviral therapy was introduced. People were surviving and living longer. And then later on, you can see this steep rise in gonorrhea diagnoses, syphilis also, and chlamydia. And this is the trend that has continued. So then obviously in 2020, coronavirus happened, and I'm going to show you on my next slide, and then I'm not going to do any more graphs after this. This is the only 2 graphs that we're going to do. So this is the last 10 years. So that steep rise that you can see more recently is sort of played out in a less steep curve here, but you can see the general trend was obviously up. So look at this line first, this dot dash line here, which is HIV. And you can see that over the last 10 years, it was quite stable, and then it started to fall, which is amazing. And that was because we've got treatment as prevention, and we know that you can't pass on your HIV if your viral load is undetectable and your HIV is treated. We also have PrEP, so we can protect or we can prevent HIV acquisition in people who are HIV negative, and we do lots of testing. So when we diagnose people, we put them straight onto treatment, so they're not at risk of passing on their HIV. So HIV diagnoses, new diagnoses, are falling. But the flip side of that is that a lot of people are having unprotected sex, and we can see that chlamydia, syphilis, and gonorrhea are both rising steeply. Obviously, the other interesting thing to point out here is that in 2020, all the diagnoses went down, but that was not a disappearance of STIs. That was just because people weren't able to get to the clinics and they weren't able to test. So whilst, it would be great to think that all STIs disappeared off the face of the earth because everybody was in lockdown and nobody was having sex, that's absolutely not the case. And I couldn't find a slide with the new data, but the new data is out and it is being talked about. But this is obviously just going back to baseline again. So large numbers of STI diagnoses being made, and unfortunately COVID had more of a negative impact on STIs than a positive impact in terms of getting numbers down. So Daniel and I work in a busy clinic. We have an amazing team. We are very together. We have good leadership. The people who tend to go into sexual health are passionate about sexual health, and I think we are very lucky with the setup that we have. However, there are huge challenges for all STI clinics across the country, and as I've just shown you, rates of STIs are going up and up. There are more patients coming through our doors, but there are also more patients being managed virtually because we have, through COVID, we've managed to set up a virtual clinic, and we have lots of people accessing testing online. The people that are coming through our doors are increasingly complex. They are bringing complex presentations. So not only are they saying, I've got symptoms, I've got pain and bleeding, they're also saying, look, I just can't take this pill. They'll come in with half empty pill packets, and they're kind of all over the place with their contraception. And by the way, I'm feeling unsafe in my relationship. So, it's not just one thing, it's you're dealing with this person as a whole, all their sexual health issues, and it can take a long time to complete one care episode, if you like. We are, and COVID is very much to blame for that, because people were indoors, they weren't accessing services. So it feels as though this is still the fallout of COVID, and that people have stored up all these problems for a while. Add to that, as if one pandemic wasn't enough, we had our own little pandemic in sexual health with monkeypox this year. So we were literally just coming out of COVID and everything was normalizing, and then we were hit with monkeypox, where we really did have to wear proper PPE in an outpatient setting, and that was really hard for us because because, you know, in COVID, actually, most of our clinics shut. So we were doing a lot of online work, whereas in monkeypox, the rest of the hospital went back to normal. We were in gowns and shoe covers and masks. And we just didn't have the setup for it, and we just weren't expecting it either. Now that monkeypox has dropped off, hopefully we can breathe a bit more, but only until the next infection comes along. We are challenged by staff shortages. I think that's just obvious. That's the public sector in general, and we struggle to make impact politically. I think politicians don't necessarily think that sexual health is important, possibly them. But we want to have a sexual health strategy, but time and again that's downgraded, or it's less of a priority for government. They do have a 5-year plan for antibiotic resistance. You know, we are dealing with this in our clinics, and the government says that they recognise this. The 5-year anti-AMR plan is very much AMR broadly, so addressing all aspects of AMR. STIs are in there somewhere, but it doesn't feel to us as though that politicians are really sitting up and taking notice. Meanwhile, gonorrhea resistance is going up, as is Mycoplasma genitalium resistance. We also have resistance in syphilis and enteric infections as well, which Daniel is going to talk about later on. So on a global scale, so this is the 5-year plan, the UK's 5-year national action plan to tackle antibiotic resistance. And there's all sorts of interesting stuff in there about what we should be doing. But obviously without the will and the money to do that, it's a lot harder. On the right, this is the World Health Organization 2014 Global Surveillance Report, which mentions gonorrhea as one of the 9 bacteria of international concern. And then on the left there, CDC published a threats report in 2019. Gonorrhea is in the urgent threats list, and Mycoplasma genitalium was put on the watch list. So that's good. It's really good to have 2 STIs on the CDC's radar, because it means that they are elevated in terms of political agenda. In the UK, we have some of the best data in the world. We are real sticklers for data, and I think this goes back to, you know, wartime when sexual STI clinics were first set up. But we are really good at collecting data. And you know, each clinic has a nominated person to make sure that the data collection is good, and that you know, all our STI data is reported nationally to UK HSA. So these are data for a gonococcal resistance surveillance program that was set up about 20 years ago. And you can see that the purple line and the green line show that there are quite high rates of resistance in some antibiotics, but actually we don't use those antibiotics primarily to treat gonorrhea. The one that we do use is the yellow line, and that's ceftriaxone, and you can see that resistance is quite low. So the main antibiotic that we use for gonorrhea works very well. It will treat almost any gonorrhea, and even if you have a gonorrhea that throws up a signal that ceftriaxone isn't working as well, we give such a big dose that should be enough to get on top of that strain. Now, that's not always the case, and we've had a handful, probably a few more over the years, of isolated cases that pop up all over the world. And some of you may remember this headline, which was just the most stigmatizing headline ever, but it's just typical of the BBC. So this man had the world's worst gonorrhea, which he actually had to come into hospital and have IV antibiotics for, because we just couldn't find anything else to treat it. This was a patient in London, I think. And he acquired his gonorrhea abroad in Southeast Asia. And since then, there have been a few more reports of this kind of gonorrhea. So although the absolute majority of gonorrhea is very much treatable with an intramuscular injection of ceftriaxone, there will be these isolated cases. And when they crop up all over the world in different countries, it just makes you think that there's something more going on. There is more resistance that's just not become apparent to us. And I think that's the worry. The worry is that these very resistant strains are not being picked up, but they are being spread before they are being treated. Then a very similar headline in the same year, only a few months later, about Mycoplasma genitalium. And this coincided with the release of the guideline and when we started testing for Mycoplasma genitalium, talking about this emerging sex disease, which could become the next superbug. It actually already was a superbug by the time we started testing for it. Notice the picture here. There's always this sort of messaging around safe sex, you know, taking the onus away from the clinicians and the onus away from antibiotic stewardship, and clinicians and practitioners prescribing sensibly, putting the onus back on the patient to have safe sex and use condoms during sex to protect yourself from these awful sex diseases. So Mycoplasma is relatively new. So MGen is one of my special interests. It's something that I developed an interest in because I actually did a study, one of the very first studies of Mycoplasma as a trainee in Brighton, and it was Daniel who actually encouraged me to do that study. So I'm obviously very grateful to him, but it led to other things, and I ended up being the first author of the guideline for Mycoplasma genitalium in the UK. And so it is relatively new, only been testing since 2018, but already UKHSA have developed a resistance surveillance program. And there are data from a couple of years, this is from 2020, but the strong signals that are coming out from this are that rates of resistance are exceptionally high. So our first line antibiotic is a macrolide. That's the thing that we have to use first if we can. 69% of the strains that are circulated, well, the strains that we've tested are resistant to that first line antibiotic. A macrolide is azithromycin. To anybody who knows anything about antibiotics, we used to use a lot of azithromycin to treat chlamydia. And I think that's where some of this resistance has come from, because we use so much azithromycin. We used it in a very small dose. It was just a single dose to treat chlamydia, but it just wasn't enough for Mycoplasma. So we have unwittingly caused this macrolide resistance problem in Mycoplasma genitalium. The next antibiotic that we have available to us that works for MGen is a quinolone. We already have about 10% resistance to quinolone, so 1 in 10 infections won't be treated with a quinolone. Quinolones are not very nice antibiotics. They have side effects. They have toxic effects to the central nervous system and also the joints and the tendons. So if you're taking longer courses, you can experience tendon problems. And then that's it. And then we've got a few other things up our sleeves, but there's really not much data to support their use at all. So we've got those two. We've already got high rates of resistance. And what else the other thing that came out of this surveillance program was that the people who are most likely to have resistance, so the people who are most likely to suffer the adverse effects of not having an easily treatable infection, were men who have sex with men, people of ethnic minorities, and particularly Black or Black British, and those who had had a previous STI diagnosis in the past year. So interesting data coming out of the MGen surveillance program. This is very similar also to gonorrhea. So with gonorrhea, we've got a lot more data, and it does tend to be MSM and people of ethnic minorities who are more likely to have resistant infections. On a global scale, looking at MGen, there are data, and the data are just really depressing. Increasingly, more papers are being published as people have access to testing and have access to resistance testing. But you can still see swathes of grey across the world, and that's where there's no data available. And we absolutely need that data to see what sort of practice is happening in different parts of the world, and where how we can start to tackle those those high rates of resistance. So China is great, but actually there are data from China, and the data show that there is about 90% resistance to macrolides. So it's much worse in Southeast Asia than it is elsewhere in the world. And that's probably because of the availability of antibiotics over the counter in places like India and Southeast Asia. I think that's all I want to say about that for now. So I thought I would illustrate some of the complexities of managing these infections with a case. And this was a young woman who came to the clinic. She presented with some pelvic pain, vaginal bleeding, and a new vaginal discharge. She had had some frequent condomless sex with a new male partner, and she had had that boyfriend for about 3 months. We examined her, we did an STI screen and sent it off. So some of the results for specifically for chlamydia and syphilis are not available on the day. You have to send away the test. You can get some results for gonorrhea on the day, but it's not always sensitive because we have microscopes in the clinic. But just because you don't see gonorrhea under the microscope doesn't mean that they don't have it. You have to send away your much more sensitive test to the lab, and that can take in Brighton up to 2 weeks to come back. But based on her clinical presentation, we suspected that she had something called pelvic inflammatory disease. And this is where an infection tracks upwards from the neck of the womb into the womb and across to the fallopian tubes. And it causes inflammation, it causes pain and swelling. And if it's not treated, it can cause scarring. And that's where the whole infertility thing comes from. So when you've had chlamydia a few times causing PID, you're far more likely to have subfertility. So at the time,
Sunita, just about 2 minutes, please. Say
that again.
Sorry, just about 2 minutes more, please.
Oh, 2 minutes. Gosh, sorry. I thought I had a bit longer than that. Oh gosh, right, okay. So Mycoplasma genitalium, so she did turn out to be positive, and her discharge and bleeding were better, but she was still having lots of pain. She wasn't pregnant, so she was given a different antibiotic, and the side effects and the risks of pregnancy were discussed. So she was offered some contraception, but she decided not to go for contraception. She had lots of questions about her partner, who was also wanting treatment. Then she came back again in 5 weeks because we always recommend having a test of cure. She developed an infection from taking the antibiotics, so she developed a fungal infection from that. She still had pain. Her mycoplasma test was positive, and it was likely at this point we realised that she had a multi-drug resistant organism. Her pregnancy test was positive, and she was unsure what to do next. We did refer her to the early pregnancy unit just because we do that with everybody who has pain and who is pregnant. So the issues for her were that she had ongoing pain in a new relationship and wasn't able to have sex. She'd have multiple visits to the clinic, lots of courses of antibiotics, and obviously those come with the side effects and the risks of taking antibiotics to her unborn child. The pain could have been due to something else, so she was now facing more investigations from obstetrics with respect to the pregnancy, and overall she was unsure whether she actually wanted to continue this pregnancy or not. So for her and for us, I guess it's weighing and having that discussion with her about weighing up the risk of the infection outcomes, which would be ongoing pelvic inflammatory disease and an early miscarriage possibly, with the toxicity of the treatment to that fetus and possible miscarriage from taking antibiotics as well. I'm going to skip that slide, and I'm just going to I'm just going to summarize actually. So in summary, so rates of STIs, I think I've very much laboured the point that STI rates are continuing to rise, and our clinics are busier than they've ever been before. The staff are challenged by the volume and complexity of work, reflecting the worsening sexual health of our nation, but they're also struggling with the decision making around AMR and when to treat, and also when to offer partners treatment. AMR does pose a real threat to the successful treatment of some STIs, and we know that minority groups are more likely to be affected. Our antibiotic stewardship messaging, so that's being sensible about prescribing and being correct about prescribing and not reaching enough clinicians. And we urgently need political engagement to address these issues. Thinking about all this and putting it together, what we can do is listen to patients and make balanced decisions together. We can make sure that patients are involved when we're designing services, and we also need to listen to our staff and hear what they have to say about how we manage these complicated patients. We need to continue to call out poor practice by other providers. By that, I mean private providers mainly, but also check that our own practice in the NHS is conforming to the standards. And we need to continue to collect evidence and lobby senior political and NHS leaders to keep sexual health on all the agendas.